Hello, everybody. Just going to wait a few minutes to let everyone log in. Good morning, afternoon, and evening to our participants who are joining us from different time zones in the Asia Pacific and beyond. Welcome to this edition of the APMEN TechTalks. I think most of our participants on today are quite familiar with TechTalks, but for those of you who aren't, just very briefly, the TechTalks was set up as an online platform last year when the pandemic first hit us. And this was primarily to serve as a way to continue the active exchange of knowledge and expertise within the network. A year in, I think it's safe to say that the TechTalks have really established themselves as a robust, ongoing mechanism for continued sharing of expertise in various technical areas related to elimination. This has been possible in large part due to the APMEN working groups that have been driving the discussions through the TechTalks. We went through a process late last year to identify new hosts for each of the working groups. And today it gives me great pleasure to introduce the incoming chair and co-chair of the Vivax Working Group, Dr. Lhazeen and Dr. Caroline Lynch. Dr. Lhazeen is the director in the Department of Public Health, Ministry of Health in Bhutan, and she's responsible for leading the communicable disease, non-communicable disease, health promotion, public health engineering division, as well as the Royal Center for Disease Control. It's quite a big portfolio you have, Dr. Karma. Dr. Karma was part of the original setup of the Vivax Working Group in 2009, and she has rich experience in helping Bhutan get to pre-elimination with available tools for radical cure. With the ongoing pandemic, Dr. Karma has also been involved in the rapid rollout of the COVID vaccine across the country. As some of you know, Bhutan's made incredible progress with more than 60% of the population already vaccinated, and they have a target of getting to 90% plus coverage of eligible adults by the end of the month. That's really quite an achievement, Dr. Karma. So thank you for joining us today, and we really appreciate you making the time during this critical phase of the vaccine rollout. Dr. Carrie Lynch is the co-chair of the Vivax Working Group. Carrie is the regional advisor for the Medicines for Malaria Venture, MMV, covering the Greater Mekong sub-region, Indonesia, and Papua New Guinea. Welcome, Carrie. The high burden of Vivax malaria infections in the region and the fact that eliminating Vivax will be made possible only with radical cure makes the goal of regional elimination that much more challenging. Countries in our region, particularly those in the GMS, have made significant progress in reducing falciparum malaria and will likely achieve elimination of falciparum by 2025. So the continuing challenge is really around Vivax. And there's an urgent need for us to prioritize discussions around currently available as well as potential new tools and technologies to diagnose and treat Vivax malaria. And who better to guide us on that discussion than Professor Ric Price. Ric is the Professor of Global Health at the Menzies School of Health Research, as well as the Professor of Tropical Medicine at the Center for Tropical Medicine, University of Oxford in the UK. He's been the co-chair of the Vivax Working Group for 10 years, and I want to take this opportunity to extend a heartfelt gratitude for stewarding the Vivax Working Group over the last 10 years. He'll, of course, continue to be a critical part of the Vivax Working Group, and we look forward to hearing his perspective on the journey that this working group has taken, and more importantly, what still needs to be done to get to elimination. So over to you, Ric. Thank you.
Thank you, Amita, and thank you to the new co-chairs. Thank you particularly to Dr. Karma, who's dialing in the middle of a holiday in Bhutan and in the middle of vaccination. So I'm going to share my screen. So just let me, I hope you can see that. Can you see that?
Yep.
Yep. As Amita said, we have made significant progress towards elimination in the last 10, 20 years. The recent figures, and I'm using the MAP figures published last year, about 22 malaria endemic countries in the Asia Pacific region with 3.9 billion people at risk. And our estimates from the MAP group slightly higher than that in the WHO report, but about 9.6 million cases of falciparum and about 12.2 million cases of Vivax. Recent estimate by Angela Devine suggests that actually globally, Vivax accounts for $343 million a year. So a huge burden regionally. So we have been making progress, and I think that's a room for applause, although some of the recent WHO reports suggest that that may have stalled. The Vivax Working Group, or actually APMEN itself, was convened in about 2009, following Australian government Kevin Rudd's commitment to supporting the regional agenda to elimination in the South Pacific, or in the Asia Pacific region. And that meeting, which was held in Brisbane, attended by several people who remained with APMEN throughout, identified a number of key challenges, and Vivax was one of those. As you can see already, even 10 years ago, we saw that we were impacting much more upon falciparum than we were with Vivax. On the left by Jetsaman in Thailand, showing falciparum going up, but the relative proportion of Thailand increasing. More recently, data from Eni Kangalam in Papua showing a rising proportion of malaria due to Vivax. And that's consistent. And when we look over the region, you can actually see that in co-endemic areas, Vivax is now the predominant species. And that's due to a number of reasons. Mainly the transmission dynamics of Vivax are very different. But the key feature of Vivax that makes it different is its ability to form hypnozoites, which can relapse weeks to months later and sustain ongoing transmission. And those relapses in the liver are not amenable to the normal xizontazidal treatments such as chloroquine or ACTs. So we really need to tackle that. And that doesn't mean to say you can't eliminate without radical cure, but it takes much longer. And I think that's important. One of the key features when you're dealing with Vivax is heterogeneity. What I mean by that, I mean there are so many variables that change in different locations. The frequency and the risk of relapse changes. And you can see here on the right, that curve is the risk of relapse following one episode, much higher in Papua and PNG and Brazil compared to other places such as India, Pakistan and Korea. So the G6PD prevalence varies, and of course, primaquine can induce haemolysis in people with G6PD. The populations at risk, supply chain and logistic, health system capacity, financial constraints, etc., etc. So there's a huge heterogeneity, and there's not going to be one single solution to how we achieve or impact upon radical cure across that. So the risks and costs and benefits will vary hugely. So the mission, which was stated back in 2009, was to enable country partners to eliminate Vivax malaria within the proposed timelines. So, and that really does require safe and effective radical cure. As I said, many countries have managed to eliminate without radical cure, but it takes a lot prolonged effort. And so to achieve our targets, really a key feature of Vivax is achieving that safe and effective radical cure of malaria. So the Vivax Working Group, when we convened, the first meeting was in Colombo in 2010. We had a cycle of how we would tackle this, and we really didn't have proper diagnostics or treatments available. So the first priority was to identify knowledge gaps, build consensus across our partnership, generate evidence, influence policy, and change the burden of disease. Initial funding from AusAid, or the Department of Foreign Affairs as it's now called, from 2010 to 2015, and then support from Bill and Melinda Gates. So the challenge of all of that actually is to build the evidence, is to build the tools, but none of that helps us if we don't translate it into policy, and policy doesn't help unless we translate it into practice and actually impact upon the disease burden. So this was our first meeting in Colombo. It was a great meeting. You can see some of the pictures down there. Much smaller group in those days, a key number of people, and you'll see some of the names: Gauchi, Albi, Rita Kuzriazatuti, and there's a picture of Dr. Karma there presenting at that meeting, and we filled the walls with everything we didn't know. It was very easy to fill what we did know, but my goodness, there were so many things that we thought were key, and we tried to bring that down into 5 areas, and they were rather nebulous, and we sharpened that up when we met in Kota Kinabalu in Malaysia the following year, and we brought them into 3 different kind of headlines: surveillance for the parasite and the host, diagnostics for G6PD and also RDTs, and then treatment for the blood stages and hipposondazidal for the liver stages. And I'll go into a bit more detail around those 3 themes in a minute. So we've had numerous meetings every year. We have an annual meeting and we try and address those priorities and see how we're doing. And it's been a pleasure to be hosted in so many different countries each year and to meet so many people on a regular basis. That's been one of the great pleasures of the APMEN collaboration. So one of the first challenges is to build consensus and agree on a way forward. And this means building trust and sharing experience and information. Often as you go towards elimination, the numbers within each country may not be huge, and therefore you're not powered to do those studies. And collectively, our knowledge gain is so much better when we collaborate on that. This picture in the top here is Lawrence von Seidlein, who did an amazing job running the technical work, the technical projects. And here he is with colleagues from Bhutan, Kinley, Tobgay, and Sonam on one of their projects. So building trust, sharing data, building capacity, and then we also brought together co-funded workshops, which were supported by MMV and PATH to look at new diagnostics and new drugs and new approaches. Those were probably the most informative ways of creating consensus. This is our model. At the very center of what we do is not a research agenda, it's the National Malaria Control Programs. They lie at the heart of APMEN, and it's the collaborations around that, and that includes researchers, the WHO, networks such as the Malaria Atlas Project Group and WARN, funders, industry, and public-private partnerships. And you see those arrows going in and out are a two-way thing, because it's not just those partners who are supporting the National Malaria Control Programs, it's actually the National Malaria Control Programs informing their needs to those other partners. And that two-way interaction is absolutely crucial. Many of the researchers who attend those actually take away and they change their research agenda so that actually they can realign and hopefully impact upon policy at the end of it. So a key aspect of the first round from 2010 to 2015 was generating evidence. And we did this through a country partner technical development program. And this was coordinated by Kylie Mannion and Lawrence von Seidlein in those 3 areas. And we put out a tender. Each project was about 50,000, so quite small scale projects to work across the regions that you can see there in that diagram, and to address a number of those priorities, and I'll talk through those briefly. So on the diagnostics, well, 10 years ago, we didn't really have a point of care diagnostic for G6PD. The only reliable method, quantitative, is spectrophotometry, which is very expensive and precludes use in the field. There is FST, fluorescent spot test, but actually the reality is that most countries and most programs don't have access to that. So a key priority was to facilitate a rapid diagnostic test at the bedside that we could test for G6PD, and that tests at about 30% threshold. So it's okay for primaquine, but it's not going to be okay for tafenoquine. And so working with PATH and FIND, we've been facilitating looking at the biosensor by CareStart and also the SD biosensor, which is a quantitative point of care test that can diagnose G6PD. So very exciting that that's come online in the last years. Still challenges in terms of looking at their utility, but we've now got tools to do that at the bedside. The diagnostics for Vivax have also been very poor. They're less sensitive than the ones for falciparum. So maybe in some circumstances down to 60% sensitivity. So not great. And again, looking at different strategies for doing that. Ultra-sensitive diagnosis for PF, as well as new tools which can actually facilitate diagnostic, and a range of products there that we've been working and testing with partners in the In the second round of APMEN from 2015 or 18 to 2020, this is funded by the Bill and Melinda Gates, we had a slightly different approach to engaging with our partners. And actually we designed a standardized survey, and this was done by Ben Lay and Jutta Mafut at Menzies, but then working with partners to have a standardized approach so that we could share data and generate it from multiple sites. And the main focus of that was novel diagnostics, and now branching into qualitative studies. So actually on how these are used and their utility in a real world setting. So not just looking at their sensitivity and specificity, but looking at their utility. And while doing that, you can actually also gain very important data on parasite and G6PD prevalence and the genotyping of the host, which I'll talk about in a minute. Case management is also a key element of this. We have two products. We have tefenaquine and primaquine. Well, 10 years ago, we only had primaquine, and we've been using primaquine since the 1960s. Tefenaquine obviously is a fantastic addition, but recent addition. So most of the world uses the low dose primaquine, and it's the total dose of primaquine that's related to your efficacy. So the WHO allows us a lower dose at 3.5 milligrams total, that's 15 milligrams over 14 days, but in high relapse areas, 30 milligrams. Why 14 days? Well, it's to spread out the tolerability over a period of time. And some people will tell you that we use 14 days because that's how long it took for a boat to get from Korea back to America after the Korean War when they were developing primaquine. I don't know whether that's true, but we are, the world by default is using a 14-day regimen of a low dose primaquine. And why a low dose? Mainly because they're not G6PD testing and they're afraid of toxicity in G6PD deficient. So you can spread it out over 8 weeks, and that's how we give it to people who are G6PD deficient, or you can pack it in over a 7-day regimen, which is what they do in China. Well, China's 8 days actually, and Brazil, which is 7 days, or you can give a higher dose, or you can give a higher dose more recently, evidence suggesting that you can give a high dose, very high dose, over 7 days with equal efficacy. And at the end of that pointy stick is tefenaquine. Fantastic, you can give it as a single dose, but not without its challenges, because you have an increasing, because it's slowly eliminated, you have a greater need for G6PD testing, and you need to do that at 70%. So tefenaquine has to be at 70%. With chloroquine, and so we can't give it with ACT. We don't have a pediatric formulation yet. And actually, it was benchmarked against the low dose primaquine at about 60 to 65% efficacy. And we know we can probably do better with a high dose primaquine. So tefenaquine's great, but it's not the solution, and it won't remove the need for primaquine in years to come. So as we've generated data on efficacy, but we now need to move towards effectiveness. What is it, the utility of these new drugs in the real world setting? And that means community engagement. It may mean directly observed therapy. It may mean some form of adherence package. There are different strategies that we must look at. And again, this is going to require a social science component and a way in which we can inform the community and the prescribers on how best to use these products and make sure the prescribers adhere and also the patients adhere to taking a complete course. Surveillance. So surveillance on the parasite side, there is a surveillance response working group, which is more individual response. By surveillance within the Vivax working group, we're looking more at population surveillance. And this is obviously at the basic standard is microscopy, but also a greater realization that submicroscopic parasitemia, as detected by PCR, is also probably four times higher than most of the microscopic. So there's a lot of malaria out there below the horizon, below the level of detection. And doing those prevalence surveys feeds into the Malaria Atlas project, which has been mapping the prevalence and the changes in the region. But one of the things the Vivax Working Group has been doing has been focusing on molecular surveillance. And this was driven a lot by Gao Qi, and where they wanted to understand whether new parasites, as you approach malaria elimination, came from outside the country or inside the country. So those are what we call geographical markers, and you can see a little phylogenetic tree down the bottom saying that we can now begin to type and actually understand whether parasites are coming out or within. But probably the greatest utility is on resistance markers, particularly for falciparum, where we're tracking K13 and multi-drug resistance, but we also hope to be able to do that with Vivax in terms of chloroquine resistance as we develop those markers. And there's also relatedness of the parasite, so we can begin to determine what's a relapse and what's a reinfection. And we've never been able to do that before. So this is some great work being led by Sarah Orban, coordinating that within the APMEN network. And also online tools and building capacity, particularly at APMEN and also in Ho Chi Minh and Bangkok. Along with parasite surveillance, we have host surveillance, and this is identifying populations at risk of recurrent malaria and haemolysis. And of course, the key feature here is G6PD deficiency, and some nice work done by Ross Howe. And Daniel Pfeffer is actually updating these maps, looking at the variants, what variants of G6PD out there, what's the prevalence, how bad a problem is it in my location, what do I need to do? In some areas, such as Highlanders in Papua, there isn't much G6PD. Similar in Ethiopia, it's A-, and actually there is less of a danger with some areas than there are in other areas, and we need to know that. There's also concerns over CYP2D6 polymorphisms. That's the metabolism of primaquine, which renders patients ineffective to that. And then new area coming up, which is being driven by Chris Drakely in London School and Eva Muller down in Weihai, over serology. And using serology to actually look at recent exposures so we can find hotspots and hot populations who have recently been infected. So over the last 10 years, and I've gone through that in very high level because our time is short, you can see that actually we've come a long way from 10 years ago where we didn't have tools, we didn't have, people were using 14-day primaquines, but people weren't taking it, so huge issues over adherence. We've now got shorter regimes, we've now got ability to test G6PD at the point of source, and we've got the tools. They're not perfect, and by any means stretch of the imagination, we've not finished the huge research agenda to improve these and to facilitate their rollout. But I think one of the key things that we realized in our last meeting in Nepal was that actually we need to move from talking about these aspirations of elimination by 2030, and we need to go into action. We need to implement those. So there was a fantastic meeting which was coordinated by Kamala Thrima and by Carrie in Nepal, where we discussed exactly those roadblocks and those bottlenecks. And this is what the foundation of the next phase of the Vivax Working Group. We will continue research along the side, but now we're moving into that implementation of the tools we have and the optimization. So final key points, new tools and strategies are ready, and they're ready for implementation. We have to have a sense of urgency. It's no good. 10 years ago, we were saying, oh, we've got 20 years to eliminate, wonderful. We've now got 9 years on the clock if we're really going to achieve some of those targets. There has to be a sense of urgency, and we have to get that out there. We also have to appreciate the heterogeneity, and that means that we need to get local solutions. I'm fed up with hearing things of you must never do this or you must always do that. Those kind of phrases aren't relevant within Vivax. We really have to work on local solutions, and that means engagement and collaboration. And engagement and collaboration is exactly what APMEN's about, and that's where the future lies. So I'm going to stop there. Before I finish, I would like to thank my colleagues here at Menzies and the team. I've mentioned most of those along in the presentation. It's been a huge pleasure to also engage and to work with so many friends and colleagues that we've made right the way across the Asia Pacific region with the National Malaria Control Programs, and meet them on an annual basis. And we'll certainly look forward to collaborating and working forward. Thank you.
Thanks, Ric. So we'll turn over to Dr. Karma to present on the next steps for the Vivax Working Group, with enormous gratitude to you for that overview and for the strong foundation that you've set. Dr. Karma, there you are.
Okay, sorry, though. Can you hear me?
Yes, thank you.
Okay, thank you. I was having problem. So good morning, everyone. And I'd like to thank the previous speaker, Dr. Ric, for taking us through his 10 years experience. And now, as he has updated you on what happened in the last 10 years ago, from few to no tools, to newer tools, better tools in the last 10 years. So here we are, the next Vivax Working Group team, about to present to you how we will be moving forward with the implementation of next slide. Can you move the slide? So I would like to let you know that the purpose of this discussion, the meeting, is to provide a high-level overview of the draft work plan that has been developed by the APMEN Vivax Working Group. And today we would like to seek your inputs, guidance, and advice from the participants on the work plan. Here, I think today we have a big group of people who are going to be also in the technical advisory group for the Vivax Working Group. And we have country partners who will also be part of this work to be carried along. And we have also various CSOs and donors and other partners. So we will be very happy to seek your guidance and advice today. And finally, we would like to present the work plan and finalize the work plan after we get this inputs from this TechTalk today from all our advisory groups and participants. Next. So as Ric has mentioned, that Vivax malaria now, as countries go for elimination of malaria, we are now faced with the challenge of having to deal with Vivax malaria, and which is predominant. And it is very tricky because of the relapse, which takes weeks to months, and so need to really tackle them in a better way. So the overall goal is to contribute towards acceleration and accelerating the uptake and implementation of the better radical tool for Vivax malaria. So what do we mean by this better radical cure? We already are aware that we currently have been using the PQ 14 days, and which is the recommended therapy. And there are now the new tools that need to be integrated as they get approved and recommended by WHO. For the older tools, the currently used tools, I think the most difficult thing is patient adherence, and we need to address that. Then, as Ric also presented, that there is high, the G6PD testing needs for the tefenoquine needs to be also of higher quality. So ensuring the high quality implementation of G6PD testing before use of that 8-aminoquinolone treatment. And also there is there are issues of pharmacovigilance that needs to be strengthened and to increase the patient safety. Next slide. And when we say accelerate the uptake of implementation, what do we mean? For the newer tools and approaches, we need to support the countries and partners to be ready for uptake when the new WHO recommendations are released. For example, whenever there is any new tools that are to be introduced in the programs and all, a lot of time is taken when we wait for the full reports and recommendations and all, and then we start implementing all these measures to put in this introduction of new tools. It really takes a lot of time because the countries have to go through their various processes of incorporating them. They have to look for funds. They have to look for evidences to say that they are really researched and good tools to be introduced. So these are the things that need to be accelerated and ensuring. And the other thing is ensuring that the submission of dossier for tefenoquine were applicable to facilitate any operational research as opposed to the clinical trial studies. So National Malaria Programs required to adapt future WHO recommendation to their country contexts. Now I would like to present the objectives the objectives are to promote collaborative research partnerships within the countries and in the region, and also sharing research and implementation experiences. And the third objective is to identify country program needs in terms of knowledge gaps, operational research, or additional research resources or expertise required to implement the better radical cure in line with the WHO normative guidance. And also the objective is also to develop options assessment tool to support the country programs to determine which radical cure may be best for their context based on the normative guidelines. And third, last is to provide tailored advocacy to senior ministry officials and financial partners based on the country program priorities. So these are the 4 objectives of that we would like to support. And now we have, we'll go on to the major activities in this to address these goals. So we have 4 activities. The first one is to develop a theory of change to identify priorities for better implementation of the radical cure for Vivax malaria. And the key outputs are the framework of regional and country priorities and knowledge gaps related to better implementation of better Vivax radical cure. And the other second output is operational research and implementation gaps across the regions identified and ranked by the National Malaria Programs and the key stakeholders. The next activity is to support the programs, National Malaria Programs, to integrate the accelerated implementation of Vivax radical cure into the ongoing activities. So here the key outputs are that the accelerated Vivax radical roadmaps developed at least in one high priority country outside the GMS. And the second output is option assessment tool will be developed for the National Malaria Programs to identify the best radical tool options for their given contexts. Like it will depend based on their different epidemiologies and their health system scenarios. These option tools will be provided so that they can make their choices based on those scenarios. Then the third one output is collation of the national and regional level evidence to address key national malaria program gaps. So here there will be a exchange of informations at national and regional levels that will also help the other countries to get information on what were the knowledge gaps and how they could be addressed. And then there's the last output in this activity is to provide a global repository for national malaria programs to access Vivax relevant documents and guidances. Then the third activity, I think you missed one slide. Activity 3. In activity 3, facilitate cross-regional learning between programs, national malaria programs, research partners. Output is the annual Vivax Working Group meeting report outlining key national malaria program gaps, status of the radical cure coverage and use, and key priorities in terms of operational research and implementation in the coming year will be discussed. And in a year at least, and we will have at least 5 tech talks undertaken that address the knowledge gaps of the programs and highlight best practices or challenges, how to address the challenges with the new tools that are approved by WHO. Then there will be a next output is the global operational research database will be maintained and updated from time to time. The other output is the global Vivax Malaria organization repository that includes at least 10 newly produced partner documents will also be available to facilitate exchange of information. The last activity is the fourth activity is to underpin all the activities with clear evidence-based communication and advocacy targeted to National Malaria Program and MOH priorities. In this is there will be key messaging around the new tools and around health systems and regulatory functions required to improve the radical cure tools or integrate new radical cure tools that are developed. And the next key output is we will be working with regional researchers highlighted through the TechTalks and social media and the Vivax Malaria websites. Then the findings and all will be used for advocacy meetings held with the key financing partners to seek support in the Asia-Pacific region and to flag the key areas that need addressing for the National Malaria Program in order to eliminate the Vivax malaria. And from the clear and transparent updates to the APMEN Secretariat will all be also one of the key outputs. That is all for the 4 activities that we have and their key outputs in this section.
Thank you, Dr. Karma. So I'm going to speak very briefly about the governance of the APMEN Vivax Working Group as we move forward. As you'll have heard from Dr. Karma, she's our new chair. A huge welcome to her, and given that she was at the initial meetings to set up the APMEN Vivax Working Group, I think there's a nice symmetry in having you chair the working group now. My job as co-chair is to support Dr. Karma, who's the more strategic thinker around these things. So I'm more of a gopher and supporter, and really someone who's just going to push and probably annoy a lot of you in my requests, but hopefully not too much. I'll do it in a jolly way. In terms of the governance, we also want to set up an advisory group of 9 to 10 people who will be consulted on this work plan, the draft work plan, and then consulted every 6 months or so over the next couple of years, and on an ad hoc basis as we need their guidance and support. The ideal constituency of that group is to have 2 country programs. I mean, it's a huge region of 21 countries, but we want to have 2 key countries sitting with us to advise us, to senior people from those countries that we've sent out the invites to. Given the importance of WHO as those who develop the normative guidance and global recommendations, we are very keen to have WHO malaria regional advisors sit with us to guide us, to brainstorm with us on the work plan and how we're doing. And so to that end, we've sent out invites to our colleagues in EMRO, CRO and WIPRO, and we've had a couple of positive responses from the regional offices, and we're very, very honoured and keen to work with them. We'll be doing that in the next couple of weeks. We also want a civil society organisation representative, and that's to really pull us down and back to the main focus of the work, and that is to try and ensure that these new tools that Ric has described are available where the caseloads are highest. And given the heterogeneity that Ric also described, that's going to be different in different areas. So we've got some very hard to reach populations that we're trying to reach with, you know, at times imperfect tools, complex tools, and what are the access strategies that we can use to get to those populations. And so we're hoping that a civil society organization rep will help us focus in on that. We're also keen to have someone from the private sector with us. We've been discussing this with GBC Health, who bring together a coalition of private sector for a couple of reasons. One, we know that not everyone utilizes the public sector in countries across the region. And 2, because we know that in the private sector, there is a lot of work done on the qualitative side to improve packaging, for example, to improve patient adherence. And adherence is a big issue that we're going to have to think through no matter what treatment regime countries decide on. So we're seeking a private sector constituent. And last but not least, we're also looking for a representative from a regional research institute with experience in implementation research. And this to really bring us to, you know, as we're at the end of that R&D pipeline, to think about any evidence that needs to be generated to inform national policy making or strategies. Dr. Karma mentioned the operational research database that we've developed. My sense is that we're missing a huge body of work from regional researchers in the region, and we're very keen, if any of you are on this call, to really engage with us and let us know what you're working on. It might not necessarily have to do with Vivax. It could be relevant to Vivax in terms of adherence, patient counselling, improving quality of care, or how we get down to those hard to reach populations. So we'll have a regional research institute to help us think about the research required to answer those questions. We're also always supported by the APMEN Secretariat in Singapore, Amita, Dr. Pong, Dimple, and I know there's a greater team with you helping us to organize the logistics of these tech talks, reach out to partners to make sure that we identify your needs. And last but absolutely not least, we're very keen to ensure gender equity and regional representation in all of the work that we do. We won't always be successful, but we are striving to achieve 50% gender equity. We know from the Global 50/50 report that there is a very limited number or proportion of women from the LMIC represented in decision-making spaces. We're keen to address that if we can. In terms of regional representation, I know that APMEN are very committed to ensuring South-South collaborations, and we would also seek to do that. As I said, we're keen to engage with regional researchers to understand their work, to understand where their gaps are, and how we can engage better with them. So as I said, we won't always get there, but we strive to be there, and we ask you to engage with us and work with us to try and improve where we can. Okay, so I'll stop there on the governance, and I'm going to move to the Q&A section. I see that there's some questions and answers popping up in the box already, which is great. Please keep those questions coming. If we can't answer them now, we'll certainly try to answer them afterwards. The slides will, of course, be available, and I think the talk is being recorded and will be available on YouTube to look at afterwards as well. Ric, I'll ask you to put on your video, please. And I'll start with the first question to you, Ric. No pressure to put on your video. There we go. Hello, welcome back. So I'll start with the first question for you before we move to the Q&A, and that is, you've presented a huge amount of work that the APMEN Vivax Working Group and partners have done over the last 10 years. But also we know that there are remaining questions. So what are those key remaining research areas or questions that you think are the highest priorities to eliminate Vivax or malaria in the coming few years?
Oh my goodness, what a question. Do you want the 3-hour answer, or do you want me to be succinct and talk really quickly?
The beauty of this virtual world, Ric, is that I can mute you when you go on too long.
You can mute me.
Just a shorter version.
I'm going to keep going until you mute me. All right. So very briefly, if we look at those 3 themes, treatment, I think it's amazing that we don't actually know what the right dose of primaquine is. We've been using it 60 years, and some people are using low dose or high dose. And the reason why we don't use the high dose is because we haven't had a G6PD testing reliable. So determining the right dose, how can we improve adherence and effectiveness is absolutely critical. Are shorter courses of primaquine more effective? Is tefenoquine more effective than primaquine? We don't know that yet. Do we actually need a higher dose of primaquine, which was benchmarked against a low dose primaquine? How can we improve access and outreach to remote areas? How can we improve patient safety? It may be that we enter an era where we don't just give people tablets, but we have to see them in 2 or 3 days' time to improve adherence and to improve safety. How can we, what's the role of radical cure with people with PF? Because we know they're also at high risk. A question on the question and answer also talked about pregnancy and G6PD deficiency. Incredibly important, and we don't actually know how to treat them, and huge numbers of 19% of people will be pregnant or lactating and won't be amenable to radical cure. How do we deal with that? What's the role of primaquine and tefenoquine in mass drug administration, and how do we optimize community engagement to meaningfully improve understanding and adherence? When we look at diagnostics, we still need more sensitive parasite diagnostics, and we need to look at the utility and cost effectiveness of the biosensor and these diagnostics in the real world. It's no good saying how accurate they are. We need to know how they are in clinical practice, because mistakes will happen and events may happen, and we have to understand that. We also need to know the optimal activity of G6PD for primaquine. It's 70% for tefenoquine. Some people are asking for 70% in primaquine high dose to rule out heterozygous females. We don't know that yet, and we need the data. We need to look at the hemolytic risk with various things. So those are the diagnostics. And surveillance, we need a high throughput, affordable molecular typing of parasites so that we can look quickly for drug resistance and also at relapse and recrudescence and the movement of parasites. We need to map G6PD prevalence and understand what variants are around, because that tells us what the hemolytic risk is. And then we also need to understand the role of seroprevalence in terms of identifying people who may have hypnozoic load and therefore could be amenable to that. Great work there, just beginning by Eva Muller's group. Haven't even talked about vector, but we leave that to the vector group. But all of this needs to be integrated and combined with appropriate vector control and radical control strategies. It doesn't happen alone. anything that we're doing has to come in with implementation studies and has to be costed and looked at the impact of what we're doing. So that's a very short, I'm going to pause, keep going for another hour, but those are for my vignettes. And please, if there are researchers out there or any of the partners who want to put their private questions, please put them down, because that's just a small selection of what I think is on the list.
Great, thanks a million. Dr. Karma, for you, a couple of questions on the work plan and, you know, working with country partners who, as you well know, are incredibly busy, especially at this time. First of all, how we identify which malaria country programs, what their needs are in terms of either knowledge gaps or implementation research that they require for their policy change nationally. And then secondly, how will we decide which countries to undertake the readiness planning in? We've said at least one country will do the readiness planning in. It would be good to just describe to people how we'll decide on those countries. That country.
So, thank you for a very good question that you have thrown at me. We know that this country's national malaria programs are really how busy they are, and we actually do not want to really overburden them with requests for updates on their activities and challenges they are facing. What we actually aim to do is reach out to the partners in the country and to keep up to date with all the to keep up to date with the ongoing activities. We hope through our advisory groups we can understand the situation in the region and the countries, and we rely on them to advise us on the country programs and reach out to them if they have any queries on the way we are going about with the prioritization and operation and going with the activities that they want to go ahead with. So this is how there will be assessment and advices and also through our partners, and the countries will also have to actually get to us if they have any gaps, and requests should be made to the Vivax Working Group for support in the area of technical support or in mobilizing resources for the country need country gap to be addressed. What was the next question?
I think the next question is how we would identify countries or the country in which we would do readiness planning or the Vivax roadmap.
For how to identify the countries that need is, I think we have to have a assessment tool developed. A tool will be, option assessment tool will be developed by the Vivax Working Group, and based on the different epidemiologies of the countries and the health system capabilities, and when available, the tools are, new tools are available or approved by the WHO, they will be matched and countries can make an option, you make use of these options through use of these tools.
Great, thank you very much. We've got lots of questions coming up in the Q&A, thank you all. I think we've got just looking through them, we've got a question on how the process undertaken to identify the activities and outputs, and how the strategy will mobilize funding to implement these activities. I'm not sure which panelist, maybe Dr. Karma and I can take that question. So perhaps I'll just start off on that. So the question is, what was the process undertaken to identify the activities and outputs? And what's the strategy to mobilize the funding? So I think, first of all, to say that our role is to support country programs in implementation, not to implement directly. So in terms of mobilizing funding, we would try to do that in response to whatever the country program needs are as they express them, if there are gaps. So we'll initially try and identify what those gaps are through something like the readiness planning, similar to what we've been doing in the Greater Mekong sub-region through the VxWG initiative with PATH and NMP. And we can describe that in more detail another time perhaps. But in terms of identifying the activities and outputs for this work plan, this has come about through, first of all, looking at the past and what Ric and the team have worked on previously, identifying and understanding the need now, as Ric expressed, to pivot towards implementation and optimization, to try and share experiences between countries as to how they're moving forward with a view to catalyzing that move to better radical cure. So the activities were identified with that in mind, with those objectives in mind. But one of the activities, as you'll see, is to develop a kind of prioritization framework through the theory of change approach. And that sounds a bit academic, but actually what that allows us to do is systematically get national programs and country programs and stakeholders to prioritize where they think the key questions, both in terms of knowledge, operational research, and implementation gaps are existing, so that we can then go to either financial partners or technical experts to try and fill in those gaps. So in essence, some of the activities are identifying what activities need to be done. So I hope that answers your question. Dr. Karma, did you have anything else to add to how we identify the activities and the outputs?
About it.
Okay. The next question is more on surveillance. Thoughts on how severely the pandemic has impacted routine surveillance data from the region and how long it might take to assess the impacts once the health system gets back to speed. Or another way, how to rapidly restart any slow progress towards elimination. I'm almost tempted to say this is for the surveillance working group, but Ric, do you want to take that question? And then Dr. Karma, I'll ask you as well, just given you're in the middle of a massive COVID vaccination campaign yourself and can possibly add to that.
I definitely don't want to answer that question. I mean, it's too difficult for me. You know, we've got people here from the programs who are living, breathing and eating it. And I think this is really going to be a local country solutions. I mean, Bu Inga asked this and that was my reply. Bu Inga in Indonesia knows us only too well and much better than us outside the countries. So I defer to the country partners. We just have to continue. I mean, what I can urge is that we can't let malaria drop, not because the resurgent will be effect for years, even after the pandemic goes. So we have to maintain our activities. We have to maintain those research activities, you know, to fine tune those. And we have to think better ways of implementing safe and effective radical cure and also actually treating patients. In Papua, people aren't even turning up to the clinics. So how can we engage them? So we have to think of novel solutions to do that. That's my only solution, my only suggestion, and it's a very paltry answer. So I defer to Dr. Karma.
I think you all have answered mostly, but the thing is that pandemic has badly affected all the countries. Even in Bhutan, we faced the impacts of the pandemic on the health system. I think the only way to build resilience is strengthening our health services to deal with such big pandemics in future and come up with strategies to reach out to people so that our work does not, the work and the achievements that we have made so far does not get, what do you call that we can keep the momentum of the work that has been achieved in spite of the pandemic. So the most important thing of lessons from this pandemic is that having very strong primary healthcare service systems and strong resilient health systems need to be built where people, the common people, do not face the brunt of such things in the worst situation. So the only answer is we should not get derailed in when we are faced with another, but use these experiences and the experience from this pandemic to build on stronger systems. And that's all, I think.
Thank you. And Dr. Karma, I think your statement is echoed by Effie, who's made a comment that the pandemic has affected not only malaria, but national programs that need to get back on track. And that in parallel with research, we also need to discuss how to build resilience into programs, especially those that are targeting elimination. And so, yeah, I think we acknowledge that. It's a huge ask when we're focusing on Vivax. And I think, you know, there's been discussions and meetings I've been in over the last week on integration and a push towards more integration given the pandemic situation. I think Effie, you know, and those of you who are thinking about these things, we ask you to engage with us and help guide us on that. So we'll be reaching out to you to understand how we can better do that when we're thinking about Vivax. Thank you. The next question on the governance structure related to WHO regional offices. Yes, we acknowledge that, just to highlight the question, it's to go back to the statement made by Ric, where strategies have to be tailored. We can't have a one-size-fits-all approach for safe radical cure introduction. And so is it not more sensible to have the WHO country offices on the advisory group? I think, yes, I can see the value of that, and that one-size-fits-all strategy we're very keen to avoid, and to ensure that there are tailored approaches in each country, as each country would want to do that. But just pragmatically, having all 21 WHO country officers in a call would be difficult, and we don't want to overburden people as well. So the idea with having the regional advisors on board is that we would hope that they are hearing from the country offices and can represent their voices to us on the advisory group. And of course, as you know, through our own interactions, we'd be interacting with WHO at different levels as well. So we would hope that through that mechanism, we would hear all voices at country level up to the regional level. There's a question, I think, Ric, perhaps you could talk to this on the challenges and opportunities in introducing neonatal G6PD testing. I think this speaks to kind of approaches to try and perhaps make these tools more cost effective.
Yeah, I think as far as I'm aware, Philippines is one of the few countries, and maybe Malaysia, which does neonatal screening. It is difficult because we also have to think how fetal hemoglobin changes over time, and whether people's G6PD status varies. There is a call to saying, well, look, maybe we should be typing communities at risk and then giving them a card and saying you are deficient or not deficient. One of the things we're showing, and this is a paper coming out in PLOS Med in a few weeks by Ben Lay with colleagues in Bangladesh, showing that actually G6PD deficiency may change during malaria. So it may actually go higher. So I think there is a danger in thinking, oh, well, let's give people a card and a status, and it won't change. It may well change. It may change with nutrition. It may change over the time. It may change with parasitemia. So I think these are different agendas. I know that there's a different rationale between neonatal screening for G6PD deficiency, but when it comes to malaria, I think I can't see at the moment how we can get around doing a point of care testing at the time when you're prescribing that. Some will disagree with that, and I know Thailand are looking at mass drug administration on the Thai Myanmar border by typing a whole load of people beforehand and then doing that. So no easy solutions on that. Sorry.
Thanks, Ric. I want to come back to a question that has been answered, but I think it's important to bring up and highlight, and that is how do we see the role of tefenoquine in the coming years for eliminating Vivax, and will it replace primaquine? And I just want to take a little bit of time to answer that from our side, and that is that we don't see any drugs replacing other drugs. It's not like one drug is the silver bullet to Vivax malaria. Primaquine is necessary. You know, there are, as Ric described, we don't have perfect tools. Tefenoquine, we're still waiting on the pediatric dossier to be approved to get through. You know, we don't have dispersible quality approved or pre-qual approved dispersibles for primaquine, for example. So we need to be able to have a mix of these tools and to optimize that mix where we can. So just to answer definitively, there's no replacement of one over the other, and we have to figure out with countries what's the best combination of tools that they can use, and that's complex.
I'd like to just second that. I think, you know, the last 3 papers I've submitted have come back with a review saying, why bother with primaquine? We've got tefenoquine. And it shows a complete lack of knowledge of the challenges of doing that. So I totally agree with what Carrie's saying. The tefenoquine is a fantastic game changer in some locations, but it's not without significant challenges. And also the G6PD. People think, oh, now we've got G6PD, primaquine will be safe. Well, that's not true. You know, there will be errors in G6PD testing, you know, 1%, even 1%, and you scale it up. Events will happen. So we, just by having G6PD testing, won't stop bad things happening. And that's why the community engagement and discussion is so vital as we go forward. People have to understand that there are risks. There's risks with every drug we take. And we need to understand those risks and not overplay them. And we have to give people confidence that actually this is going to have a huge effect, and it can have a huge effect.
Great, thank you. There's a comment on qualitative approaches. Mixed research approaches could be cost effective with taking a random sample from a quantitative component to interview and analyze data. And I think another comment on qualitative approaches. I just want to take a bit of time. Yeah, a qualitative approach would be useful to find out various aspects of malaria non-compliance. I think one of the things that we're seeing with the operational research database, this is a database that focuses on ongoing research across the region, to which I'd encourage people to add their research. We're not asking for results, we just want to know what's going on. But one of the big gaps that we're seeing in that database is qualitative research and social sciences that you mentioned as well, Ric, to understand, you know, acceptability of these new tools at various levels of the health system. Again, as someone has mentioned, why is there non-compliance, or how can we improve compliance with PQ14 and PQ7, for example? So I would encourage any researchers who know other researchers who are working in these areas on social sciences and also on policy processes to please engage with us, go to the VxWG.org website and put your research up there. We want to be able to draw on your expertise over the coming couple of years through TechTalks and otherwise to get your findings to the ears of the national program so that they can design their strategies in a way that improves adherence and other aspects. Okay, I'm just trying to read these as we go, apologies. So there's a comment that APMEN could also contribute by co-funding researchers for the program, and this would no doubt contribute towards Vivax Working Group targets. Ric, maybe you could talk a bit about how the research was funded previously in the working group, and then yeah, I think we should just talk about the resources going forward as well.
Well, thank you, Kinley. I mean, it's an important point. We did have funding in the initial grants to do research, and actually research was the wrong word. We called it evidence, generating locally acquired evidence. And many of the proposals we had weren't relevant. They tended to be less relevant to the actual practice. So it's a balance between research aspiration and the needs of the National Malaria Control Program. But there are clearly some things, if called for by the national program, in terms of evidence that is needed around local issues or G6PD prevalence or whatever, then those are very important. Now, we had some funding within across, so we tried to standardize that approach. The first phase was more ad hoc, and people would say, oh, I'd like to do this. And we said, yes, we'll support you. We don't have that privilege anymore. And that's why the second phase of the research agenda was us being more prescriptive about giving people the tools. I think it's a big ask. There isn't funding to support research agenda, but I think the role of APMEN, and we've talked about this extensively, is to provide expertise within the network and leverage other funding. So make partnerships through your APMEN network. You've got fantastic research partners that want to work with country partners, and we can work together with you to access additional funding. I don't think you can look to APMEN to be funding the research component themselves, except in certain very key areas that the advisory board is going to come to. So I think it depends on the question, relevance, and it depends on how we do that. But you have a lot of partnership within this collaboration that are very keen to support those kind of activities. And we have access to welcome NHMRC, maybe Gates, you know, if we get the right project, we can help you do the research. So very happy to discuss all of that. Thanks, Ric.
I would also say that, you know, you presented a huge amount of work that has been done over the last 10 years. And there is also, we know, work ongoing in countries. So there is evidence that's been generated that perhaps needs to be synthesized and collated into evidence briefs to make more accessible to country programs and digestible for that decision making, to aid that decision making. So we can't ignore what's already being done in the region. And so we want to clearly identify where the gaps are to be able to focus on those.
Can I just jump in on that? Sorry, I'll probably say one more thing. Someone asked that question around G6PD, how do we do it? And I think Kerry's point is really crucial in that we need to collate what data we have. And we're doing that within G6PD, and we'll be updating those and sharing that. We're also trying to do this. So we are trying to do systematic reviews, and we would love people to contribute to those. And then when we find an area of no data, that's when we can leverage resources to do that. So I totally endorse, you know, not duplicating data which has already been gathered, just isn't being used.
Excellent. Okay, we have one final question, but I've been told that we have to wrap up. And that question is on the role of primary healthcare strengthening across the region towards Vivax elimination. I think that's too huge a question to answer right now. Ric, I see you're going to type an answer. Thank you. But I would say, for anyone who's got any ideas on how to do this, how to answer these questions, you know, we don't have all of the answers, and we're very keen to hear from you, and we're very keen for you to engage with us and talk to us about how we can do this, how we can better improve things, either in terms of our governance or in terms of the work plan, or thinking of those key questions that have been outlined as we go forward. But on that note, I'll say a huge thank you to the presenters, especially Ric, for all of that tremendous amount of work that you've done over the last 10 years, for being a charismatic, outspoken voice for Vivax. Thank you so much for the strong foundation you laid for us. To Dr. Karma, I know you're in the middle of a massive COVID vaccination campaign. It's very inspiring. Thank you so much for taking time to sit with us today, and to our colleagues in the APMEN Secretariat and all the participants for engaging with us and talking to us today. We value your inputs, and we'd like to hear from you more. I to encourage you to please answer the poll. Don't drop off yet. There are just 3 questions, I think. So please, if you could just take time to input into that, we would appreciate it.